So we are recording. I will stop at the end of the presentation and unmute your microphones to allow you to ask questions. But for the purposes of getting through the material today, I'm going to mute the microphones and record the presentation. Again, I want to welcome you all and thank you to Dr. Atta for organizing this session. I'm sitting in my home in Canada. We're on shutdown or lockdown here because of COVID. So it's fortunate that I had some time this morning to visit with you all. Thank you for taking time out of your busy schedules to learn more about the EFFORT trial. This is a very important question for us as a critical care nutrition community. If you look at the document that was published a few years ago about our priorities as an intensive care community, sorting out the optimal protein dose, figuring out how to feed these nutritionally high-risk patients is a top priority. So this project is super important to our day-to-day practice as we screen and assess critically ill patients and basically are trying to sort out, well, how much protein should I be giving them? And so we aim to enroll over 4,000 critically ill patients who are at nutritionally high risk. And I'll define more what I mean by that in a few slides. These patients will get randomized to either 2.2 grams per kilogram per day or what we consider to be the usual standard of care, 1.2 or less grams per kilogram per day. And then we follow them for basically hospital outcomes. So any data, any outcome data that you can obtain from a hospital record, that's what we extract from the hospital record. So this trial, I want to say a little bit about the background of the trial, because for many years we have been auditing nutrition practice around the world, and we've had hundreds of sites, ICUs from around the world, not too many from Africa, although we have some from South Africa that have contributed, some from Asia, but it's been an audit where they would there's no intervention. They just go in and record something about the patient, something about the nutrition practices, and of course the hospital outcomes. And the reason they participated in this international nutrition survey was they would get a benchmarked report that would, for the various guidelines that we've established, it would identify how their site performs relative to all sites in the database. And because there are some regional characteristics that influence nutrition performance, we would also compare them to sites from similar geographic regions. And so this feature of getting the data that you put into REDCap to participate in this trial, we still will feed back to you in this way where you can evaluate your nutrition performance compared to your peers, compared to all other sites in the database. And so that's one of the value adds for contributing to the EFFORT trial, as you continue to get this kind of feedback. But this experience of working with hundreds of ICUs around the world led us to wonder if we could actually learn as we go, if we could take this practice-based audit and perform a randomized controlled trial where, as that clinician, as that dietitian is doing the assessment, constraining them to be randomized to one strategy, meaning a high dose of protein compared to a usual care dose of protein. And that's the only thing we're interfering with. Everything else is still the same as the International Nutrition Survey. And that's what we, excuse me, that's what we mean by a registry-based trial, is it's nested within this audit. And so the audit is driven by volunteers. There's no funding for this trial. The expectation is you as a clinician are interested in improving your practice. And so you will collect data on the patients the nutrition practices and the outcomes. But the only difference with what we're doing here with the effort trial is we're randomizing the healthcare practitioner to prescribe either that high dose or the usual dose. So we have been up and running since the beginning of 2018. So we aim to enroll 150 sites. We only have just over 80 sites registered and participating in effort to date. This map of the world gives you a sense of the global spread and where we have all our ICUs. And right in the center, you can see we don't have too many participating from Africa or the Middle East or even Asia. And so we welcome your participation. So far, we have 731 patients randomized from 84 different ICUs around the world. So again, just to go back now over some of the details of the effort trial, I'll talk more in detail about the various components of this trial, the intervention, the patient population, and the outcomes. And then we'll talk a little bit about the process of qualifying and getting involved in the trial. So the research question is, what is the effect of prescribing a higher dose, greater 2.2 or greater grams per kilogram per day of protein amino acid administration compared to a usual care dose of 1.2 grams per kilogram per day on 60-day mortality? In order to participate in this trial, you have to have equipoise, or another way of saying that is you have to have uncertainty about what the right dose is. And Dr. Atta was mentioning at the beginning that there's a lot of confusion, or we're not really sure whether I get 1.2 or 1.5 or 1.8 or 2. And that's okay. We want to build on that uncertainty in order to participate and conduct the effort trial. So clinicians, yourselves, the doctor colleagues that you work with, we all have to be willing to allow the randomization schema to determine the prescribed dose. If you have a fixed idea that protein is harmful and we should minimize the amount of protein, and then you're not willing to prescribe a high amount of protein to critically ill patients, then you shouldn't participate in this trial. And the converse could also be said. If you have a belief that high protein is super important, and so you're not willing to allow your patients to be randomized and therefore randomly allocated to either the high or the usual dose, then you shouldn't participate in this trial. So there has to be a level of uncertainty as to what the right dose of protein is. And in order to help with that uncertainty, we've created very short and concise reviews on the pros and the cons of protein administration. And I'm not sure if you're familiar with our website, www.criticalcarenutrition.com, and in particular, the feature called the Nibbles. These are really concise reviews on some topics. And so I'll refer you to this. If you want to read in a very concise way, what are the advantages of giving high dose protein? What are the disadvantages? What are the signals of harm? I'm not going to go through that background data. It's contained here in this nibble. It's also contained in the research protocol for the effort trial, which is on our website. And so I'd encourage you to read that summary. And there's also a very similar paper published in NCP by Jay Patel in 2019 and myself. And so we've published literature trying to say, hey, look, there's some signals that giving high amounts of protein into the 2.0 or more range is beneficial, but there's also some signals that protein impairs autophagy, impairs mitochondrial function, is associated with worse mortality, worse time to discharge alive from ICU. And so we're left in this conundrum, and we don't know what the optimal dose is. And so for the effort trial, we take what we consider to be usual or standard care, and then we randomize them to more, try and get them up into that 2.0 range. And that is what we're doing. So this slide actually summarizes the intervention where patients are being prescribed 2.2 or more grams per kilogram per day, or usual care of 1.2, but no more. You can give less, but no more than 1.2. And I want to stress that this is the only feature that is protocolized by the effort trial. It's a very pragmatic, real-time, real-life trial where everything else occurs as per usual, as per your usual standards in your ICU. And so you may have questions about, well, you know, what nutritional solution do I use? And I'm not going to prescribe one nutritional solution. You may have questions about what nutritional protocol or feeding strategy should I use? And I will endorse some of those protocols just because some protocols are better at achieving higher protein intake. So I am concerned that you do have a protocol, and I will make some recommendations, but I'm not being prescriptive as to thou must use the product. I am concerned that you do have a protocol, and I will make. Sorry, I'm just going to mute. I'm just getting some background noise, and I'm not sure why I can't mute everybody. Okay, it's gone. All right, so what I was saying was the only thing that we're intervening with is the prescription. Everything else is as per your usual standards. We do recommend that you use a pre-ICU dry weight to establish the weight used to determine the amount of protein. We liberally allow you to use whatever strategy, enteral, parenteral, protein supplements that you have available to you to meet those protein targets, particularly in the high dose group. We know it's difficult to meet those high dose protein targets. And in fact, we define success as getting at least 80% of that which is prescribed. So again, the randomization schema is for the amount prescribed. Obviously, those that get prescribed more should achieve more, and therefore that more protein should translate into better clinical outcomes. One of our concerns is that you not overfeed energy. We don't see any benefit from optimizing energy intake, but rather protein intake. And we expect that the energy prescription and the energy intake should be the same between the two groups. And what we really want to see is a difference in the protein prescription and thus the protein intake. I'll refer you to the Aspen SCCM guidelines on the energy prescription. You can see those here just while I handle. So you can see that we've just followed the guidelines there with respect to the obese or non-obese patient and how much energy we're prescribing. I want to share with you that so far to date, we've had some success in creating a difference between the two groups. We're a little worried that there's not enough separation between the two groups. You can see the usual care group is getting about 0.8 grams per kilogram per day, and that's consistent with past year's audit work where we observe that consistently, where people are prescribed about 1.2 and they only get about 0.8. But in the high dose group where they're prescribed 2.2, they're only getting about 1.5. So the difference is about 0.7 grams per kilogram per day. Now that is still the largest difference, one of the largest differences between the two groups to date, but we'd like to do more. And so I'd like to spend just a few more slides on exactly what strategies that you can use to create the difference between the two groups. Here's one of our best sites from Guadalajara, Mexico, where you can see these are days on the x-axis and the amount of grams of protein that the patient actually receives. And so in the high dose group, right away, they're able to get up to into that 2 range, and that stays sustained for a long period of time. And in the low dose group, they're not getting as high as quick, and they stay exactly where they need to be for a long period of time. So it creates a nice separation per group. And this is what we want to see happen in all sites. But unfortunately, we have some sites who are unsuccessful at creating that separation between the groups. And I'll explain in a few slides how we are auditing your data. And if we find this happening with you, we will reach out to you for a telephone call, talk about what's happening in your unit, make some suggestions on how to better improve your nutrition delivery. And unfortunately, we've had to stop a few sites from participating because they're just not able to create that separation between the two groups. One of the delights that we do have, though, is again connecting with outstanding clinicians from all different parts of the world. And we try and profile them and their teams on our website and talk a little bit about what they have found are the key features of success for their ICUs and their nutrition performance. And so I would recommend that you check that out on our website if you want to learn about what other best of the best units are doing. One of the common features across all of these ICUs that do really well is they implement the PEP-UP protocol. And I have one more slide that I'll explain what that is, just in case you haven't heard about that. The other important choice to make is that to the extent possible, you're using high protein containing enteral solutions. So if you have a choice between 2 different solutions and one contains a bit more protein, go for that one so that the amount of protein relative to energy is greater in the enteral solution that you're providing. One of our biggest concerns is we see an underutilization of protein supplements. And again, I know that some of your settings may not have protein supplements, but to the extent that you do, we strongly encourage that you use those from the beginning at a high dose, and I'll illustrate what I mean by that in a second. Parenteral nutrition, if it's a strategy available to you, or parenteral amino acids, or a combination of all of the above. I want to say that I've actually given a whole lecture on strategies to optimize enteral nutrition, and that's available on our Critical Care Nutrition YouTube channel. And when we send this slide deck out, you can actually, this link will connect right to it. And so I recommend that you review that as a strategy to optimize nutrition intake in your ICUs. Let me briefly introduce you to the PEP-UP protocol. I made reference to it earlier that this is a very cutting edge and innovative way of feeding enterally so that we optimize the nutrition intake. You know, normally ICUs around the world use a rate-based approach where they prescribe continuous enteral nutrition at a particular rate, like say 25 or 50 or 75 cc's an hour, depending on the protein energy requirements of the patient. With the PEP-UP protocol, we switch that language to a volume-based approach. So instead of getting so many milliliters per hour, we say this patient needs 1,500 milliliters per day or per 24-hour period in order to achieve their protein energy requirements. And that allows the bedside team to change the hourly rate as needed. You know, there's many interruptions to the enteral nutrition, and so there needs to be a way that the bedside team can flex up or flex down, increase the rate or decrease the rate as necessary by giving a volume goal that we enable that bedside team to do that. And we also, as part of the PEP-UP protocol, encourage people to start with a very high protein solution using protein supplements empirically right at the beginning. Don't wait for a protein debt to be detected before you use protein supplements. Use them empirically. and then you can decrease the amount or even stop them if they're not needed. We make a weak recommendation for a semi-elemental solution rather than a polymeric as your start strategy. If they're tolerating that after a couple of days, then you switch to a polymeric. I know that some of you don't have access to semi-elemental or elemental solutions, and that's fine. If you don't have access to it, you can run the PEP-UP protocol with the polymeric. It's just there's a bit of a higher likelihood of tolerating your nutrition if you're getting a semi-digested solution. And so that's why we make that recommendation. Again, just initially until they establish tolerance, and then you switch them to the polymeric. And then, as I've already said, empiric use of motility agents, empiric use of protein supplements when you start the enteral nutrition, just to kickstart the gut, kickstart the protein intake. And then as the gut's tolerating, you can stop the motility agents. As they're reaching their protein targets with enteral nutrition alone, you can tailor or discontinue the protein supplements. What this is trying to do is put our best foot forward, use maximally the tools that we have available to us to move the nutrition forward, rather than perhaps a reactive approach, which is what we've done historically. We wait for intolerance to develop before starting motility agents, for example. So that's what the PEP-UP protocol is, and I would refer you to our website for more information on that. We've got tools to help you implement that in your unit, not just for effort patients, but for all your patients, so you optimally deliver nutrition. And now here, I'm going to go through these quickly because, again, I refer you to that YouTube video where you can get the details of the presentation. But there's emerging literature that these high protein containing solutions enterally also help better deliver more protein intake to critically ill patients. There's papers published showing where you can give up to 1.0, up to 1.5 grams per kilogram per day of protein via protein supplements alone, so that when you look at the amount of protein people are getting from the enteral solution and the amount of protein they're getting from the supplemental protein, then in the combination of those two gets you above the 2.0 grams per kilogram per day. So in divided doses, 1 to 1.5 grams per kilogram per day of protein supplements. Now, you'd never want to feed somebody with protein supplements alone. They need a source of energy. So that's why you're still using your enteral nutrition, standard enteral nutrition, say at, they're going to get 1.0 grams per kilogram per day of enteral nutrition, of protein via the enteral route. But then on top of that, you top them up with supplemental protein to get them into the 2.0 range. And then the final strategies are from the parenteral source. And if you don't have parenteral nutrition, or if you don't have a high nitrogen containing parenteral nutrition, this will be a problem for you, and we recognize that. But to the extent that you have high nitrogen containing solutions, use them as a way of topping up your patient, your nutritionally high risk patient, so that they get closer to the goal of 80 to 90% via the enteral or parenteral route, compared to enteral alone, where you're only getting 60 to 70% of protein calories. When you use these strategies in combination, you're more likely to get closer to that target of enteral and parenteral. And I won't go into the details of the top-up study, but there are some signals there where these nutritionally high-risk patients who get topped up supplementally with parenteral nutrition have better outcomes in this trial. And then lastly, I'll just refer you to a trial done by Gordon Doig called the NephroProtect trial, where he used, in this multi-center trial, IV amino acids alone. So not as part of a parenteral nutrition cocktail, but rather independently IV amino acids on top of the enteral nutrition, standard enteral nutrition, to get those patients close up to 2.0 grams per kilogram per day. So what I'm not really going to make a comment about why this trial failed to show efficacy. I will say it demonstrated the safety of this approach, And all I'm trying to say is it's a reasonable strategy to try and get people into that high dose protein amino acid range of what we're prescribing. Let's now talk about the patient population that we're after. And I use the language nutritionally high risk. And I've done a lot of work developing the Nutrix score. We're actually not using the Nutrix score as an entry criteria in this trial. The feedback we have gotten from clinicians at the bedside as they're trying to participate in the effort trial is it's too time consuming in their busy days to stop and calculate an Apache score and a SOFA score, which are prerequisites to calculating the Nutrix score. Now, realize that in the data you do collect for the effort trial, and I'll underscore this in a few slides, you still are collecting the Apache score and the SOFA score, but you can do it at a more relaxed time, even when the patient is finished being on the effort trial and you're just collecting their data now retrospectively. So we will be able to do a subgroup analysis based on high versus low Nutrix score. But the other criteria prospectively, or what you're looking at on this slide, is how we consider defining nutritional high risk. Some people think that all ICU patients are high risk and therefore warrant aggressive treatment. I don't believe that. I think there's tremendous heterogeneity or variability in severity of illness and underlying risk factors. And so we need a tool that better discriminates the risk, the nutritional risk, the likelihood that this person will benefit from optimizing their nutrition intake. So I'm not talking about standard definition of malnutrition. That's one of the entry criteria. That's one of the things that makes people benefit more from optimal nutrition. And so you'll see in here that moderate to severe malnutrition is an entry criteria. But there's others, such as having a low BMI or a high BMI, being frail, having sarcopenia, or frankly, any patient who's expected to stay more than 4 days immobilized on their back on mechanical ventilation, they're at high risk, or said differently, they'll benefit from being having their nutrition optimized. So let me just talk a little bit about each of those individual nutrition risk factors. We don't stipulate what nutrition risk assessment you do to define malnutrition, moderate to severe malnutrition. So whatever your local standards are, and they vary around the world, so therefore we can't standardize or enforce this is the tool or this is the way that you're going to define moderate to severe malnutrition, but rather we let you make your definition and then we collect the components of those definitions. So you're going to tell us, was it because they had an unintentional weight loss or a reduced food intake or a low BMI, et cetera, et cetera, et cetera. So just to clarify, you use your local standards, but when you do tick that box saying this patient is eligible because they have moderate to severe malnutrition, you will be asked to identify what were the criteria you were looking at to make that definition. I've been part of an effort to define how sarcopenia or low muscle mass is a nutritional risk factor, or to say that differently, people with low muscularity, they have worse outcomes in critical illness than people with normal muscularity. And so it's always led us to the question, well, maybe people would benefit more. Those patients with low muscularity would benefit more. We've used a number of imaging techniques, including ultrasound and CT scan, to define those patients with low muscularity. But unfortunately, those are not practical in the setting of a multi-center trial where right at the time that you're screening your patient, doing your assessment, we're expecting you to randomize them. And so we're not using what we think the state-of-the-art technique is, ultrasound or CAT scan to define low muscularity, but rather we're using a questionnaire-based approach, which as you look at those questions, you see they really focus on functional status. And so if someone doesn't have a high level of functional status, it's a clue it's indicative that perhaps they have low muscularity. So it's a brief questionnaire. It's something that you will ask either the patient, well, they're not likely to be able to respond if they're critically ill and able to be entered into the effort trial. You're typically talking to a family member then. And so you're asking the family member, a proxy, about the patient's ability to lift, the ability to walk across the room or transfer in a chair. And remember, this is pre-ICU. This is not currently how they are in the ICU, but rather before they got sick and came to hospital, what were they like? Were they able to lift and carry 10 pounds, for example? And patients who have a score of 4 or more on this sarcopenia questionnaire, they meet that criteria of being sarcopenic and being eligible for the trial. Since we started this trial, there was an interesting paper published from Japan where they categorize people. These are patients who are septic in their ICUs. They happen to have CT scans done, so they were able to characterize patients as having sarcopenia versus not having sarcopenia, and then they further categorize them into early enteral feeding versus delayed enteral feeding. So if you are non-sarcopenic, it doesn't look like the early introduction of feeding has any impact on outcome. But rather, if you are sarcopenic, being enterally fed early is associated with a significant reduction in mortality comparing to delaying the feed. And in a regression model, again, in non-sarcopenic patients, there's no impact of feeding. Time to antibiotics was more important to outcome. But in sarcopenic patients, early enteral feeding was associated with significant reduction of mortality. So again, this is not a randomized trial, but it's indicative or supportive of the concept that sarcopenic patients are going to benefit more from an optimized nutrition approach. So that's one of the risk factors we look at when we think about enrolling people into the effort trial. You may be aware there's a relationship between sarcopenia and frailty, but if you look at that relationship, it's not a one-to-one relationship. This is frailty as on the frailty index. This is sarcopenia as reflected by the cross-sectional area of the rectus femoris. And so the higher the frailty, the lower the muscularity, which makes sense. As you increase your muscularity, there's probably a lower frailty score. But it's not a one-to-one relationship. And so independent of that sarcopenic questionnaire, the second questionnaire that we use, that we want asked on all enrolled patients, is the clinical frailty scale. This is a very easy to use, very brief questionnaire. Again, you're asking the family member, tell me what your loved one was like before they were in hospital. Look at the images or the pictures on the left side, which best represents your loved one. And then once you sort of locate it based on the image, you read the text to the right to confirm that in fact this best describes your loved one. I'd encourage people to read the one above, read the one below, just to confirm again that that image is best reflective of the performance, the fitness, if you will, or the frailty, if you will, of their loved one. And so our hypothesis is people who are frail will benefit more from the optimized nutrition or the higher protein dose than people who are not frail. So in this slide, I'm summarizing the inclusion-exclusion criteria, and the key inclusion criteria then are being an adult at nutritionally high risk, which I've gone over those criteria, who are mechanically ventilated and expected to be mechanically ventilated for an additional 48 hours. We don't want people who have short stays in your ICU because they won't contribute to answering the study questions. So if they come in and they're not that sick and you put them in the trial and they leave the next day, well, they wouldn't have had much exposure to nutrition or to protein. And so they're not going to help us answer the study question. So by requiring that they have at least 48 hours or an expected 48 hours of time on the ventilator, we're selecting out the sicker, the longer staying ICU patients where we think nutrition will make a difference. I strongly believe that many of the published large multi-center randomized trials of different nutritional strategies where we've failed to show a difference in outcome of optimized nutrition is because we've been taking all comers, a very heterogeneous group of ICU patients. So the EFFORT trial tries to not repeat that mistake, and we are selecting a subgroup, those that stay long, and even a further subgroup, those that stay long and are at nutritionally high risk. Those are the patients we want enrolled in the EFFORT trial. So I know many of you are saying, oh, well, I don't see a lot of those. We have patients who had high-risk surgery, they come into our unit, they leave the next day. Well, those are not the patients that we want. We only really want you to enroll 1 or 2 patients a month. So hopefully you'll have at least, 1 or 2 or more a month that you can put into the trial. So don't think that you're going to be able to enroll all of the patients in your ICU. No, we want people who are nutritionally high risk, who stay a long time. We have very few exclusion criteria. You can imagine if somebody has already been in your unit for 3 or 4 days, and they've already been exposed to variable levels of protein, that it's a little too late then to randomize them to a higher or usual care dose of protein. So you have 96 hours from when mechanical ventilation starts to when you should randomize them. As I was alluding to earlier, if somebody comes in and they die right away because they're super sick, unfortunately, again, nutrition is not going to impact that. So expected death or withdrawal of life-sustaining treatments within 7 days of screening. So it's really important that you communicate well with the ICU doctors to get their sense of, is this patient going to be here for a week? Or are they going to be super quick out of here because they're doing well? They're going to be extubated tomorrow. Or no, they're not very well. I'm expecting them to die. Or their family's coming in. We're going to have a conference about withdrawing life-sustaining treatment. So communication with the clinical team is super important to make sure we don't enroll the wrong patients. Because we don't know the effects of high-dose amino acid on the fetus, we exclude people who are pregnant. And exclusion criteria number 4, that was a requirement from a safety point of view that we allow on an individual basis, that if there's something unique about that high-risk patient who's going to stay a long time where you're not comfortable allowing the randomization feature to randomize them to either high or low dose protein, we had to give you an exclusion criteria. So remember I said at the start of the talk that if you adhere to these strong beliefs that high protein is good or that low protein is good, and you don't have that state of equipoise, then you shouldn't participate in this trial. Now, some sites have that state of equipoise in general, but around a particular patient, let's say it's a burn patient with an abdominal injury who's got a high output fistula and lots of wounds, and they're losing a lot of protein. So they're just not comfortable in that particular patient, given their characteristics, to randomize them. So they can exclude them as using exclusion criteria number 4. I'd like to say a little bit more about that, because that has been the major reason why otherwise eligible patients get excluded from the EFFORT trial is clinicians are saying, oh, well, this patient requires either a high or a low dose of protein. And here's the reasons they give, that their kidney function is getting worse, and so I don't want to give them all that protein. Or we're starting dialysis, and so they need a higher dose of protein. Or they've got a high BMI, and so they need high dose protein. And I'll just say to you that there's no randomized controlled trial level of evidence to support any of those beliefs that people in kidney function or people on dialysis, need a higher amount of protein, or that people with a high BMI need a high amount of protein. I know what the guidelines say, but I also know what the evidence base underneath those guidelines in obesity are. There's 2 randomized controlled trials of 46 patients, 13 of which were ICU, and the primary outcome was nitrogen balance. And what I'm trying to say is there's no strong evidence to support that a high BMI patient needs high protein. And so rather than exclude these patients, we would rather they be included in the trial. And then we can sort out in a subgroup analysis whether those patients in fact benefited. So we frequently get questions about, oh, well, my patient's in renal failure on renal replacement therapy, they're losing a lot of protein in that, or amino acids in their dialysate, shouldn't I be giving them a higher amount? Well, again, there's no RCT level of evidence to support that assertion. It's physiologically sensible, and people do it, so you can't be criticized for it. But what we'd rather do is have those kinds of patients enrolled in the trial, and then let us have a subgroup of randomized patients with, on dialysis. It'll be the largest randomized, that subgroup will be the largest randomized controlled trial of people on dialysis getting high or low protein. So we'll be able to, make some evidence-based comments about whether that patient population benefits from higher protein or not. Patients who are very catabolic, like I mentioned, the burn patient or the trauma patient, again, there's this idea that, oh, I need to give those patients a higher amount of protein. And I would again say there's no RCT level of evidence to support that assertion. It may be consistent with your practice patterns, but I remind you that there's an equal body of literature that says high dose amino acids are harmful. And so you could be committing a harmful practice. And it's really the lack of RCT evidence which is our problem. And so that's why we created the EFFORT trial, and we want these kinds of patients to be in the trial. And a priori, we've already specified, we have several subgroup analyses where, based on their age, their severity of illness, their case mix, the presence of malnutrition, wounds, and there may be others that we develop post hoc, will explore the merits of higher dose protein compared to usual care. So I hope I've been clear. We're trying to encourage you to put as many of these patients with these unique characteristics into the trial so that we can do randomized controls trial subgroup analyses. Nevertheless, I do acknowledge that there may be some unique patients that you're not comfortable with either the high dose, you're not comfortable with either the low dose, and so you do have the right to exclude them. That's one of the exclusion criteria that you have. So I've said, I've described the intervention, I've described the patients that we're after. I'll just briefly talk a little bit about the data collection. Those of you that have participated in our International Nutrition Survey in the past will be aware of, we try to characterize the patients who are in the trial. We try to characterize their nutritional status, and we collect a lot of data on their nutritional processes, when the feed started, what you gave them, how much they received, et cetera. And then some safety and tolerance data looking at labs. We're not protocolizing that you must measure glucose daily or must measure renal function. What I'm saying is when you clinically measure those safety metabolic parameters in the lab, we would like you to abstract those from your hospital record and put them into the data collection system that we've created so that we know as well what they are. The words in red are new or are different than our historical International Nutrition Survey data collection. So I highlight, and I've highlighted that already in the presentation, that we're now capturing malnutrition determination and we're using frailty and sarcopenia questionnaires. And so that is a bit of work, extra work, and it involves getting the family on board to help you answer those questions. The outcomes, these are all outcomes that should be available from a hospital record. You're not required to do any assessment directly to the patient. I mean, I would have loved to have captured hand grip strength at discharge, or I would have loved to ask you to phone them 6 months later and administer a quality of life tool. And if some of you are interested in those kind of sub-studies, please reach out to me, because we do have groups around the world that are trying to get some extra measures. Those will require consent. Those will require a little bit more time on your part. and so they're not part of the main trial. Everything that we collect is for the main trial is accessible through the hospital chart. And again, a lot of this is just, durations of stay in the ICU, in the hospital, on mechanical ventilation. In red ink, I'm highlighting that we are also trying to comment on the influence of protein on the PODS score. PODS is persistent organ dysfunction. And so you'll see we're collecting data on the use of vasopressors, renal replacement therapy, and duration of mechanical ventilation. So that's the trial details in a nutshell. I'd like to, I know we only booked an hour. I hope some of you can stay longer. I probably have another 10 minutes where I'm trying to explain to you now how to get involved in the trial and some of the issues that we've highlighted from monitoring several sites already. And then again, I'll stop and I'll take the mics, open the mics and take any questions that you might have. But what I'm trying to illustrate with this slide is that there is a registration process online where you'll tell us a little bit about yourselves and you'll answer some questions, and then you'll submit to us for approval before we'll allow you to participate in the effort trial. So it is an open trial. Anyone is able to participate, but we do have to qualify you, if you will. And here are the criteria that we look at to ensure that the right sites and settings are participating in the trial. We ask the people reaching out to us saying, hey, I want to get involved in effort. We need to know that you're knowledgeable about best practices in critical care nutrition. And so either some professional certificate or a CV, we're not too fussed about what, just that you demonstrate to us that you are trained in critical care nutrition. The other requirement is that you have training on good clinical practice. I'm actually not sure of what resources you have available to you in your parts of the world about obtaining good clinical practice. There are some online modules, and we can actually point you to ours in English that you can use to obtaining that training. So that certificate that comes from that online GCP, or good clinical practice training, is another requirement. We ask you to tick a box to say that you have equipoise and you're willing to follow the randomization schema. We don't want people being involved in the effort trial who, let's say they've got a patient, they enroll them in the effort, they push the button, they're told whether to prescribe high or low, and then I don't want to do that. I want to give this patient, a low dose, and they were actually prescribed high dose. So if you're going to violate that randomization schema, we can't have you, be a part of this trial. We ask you to confirm that you have some form of standardized feeding protocol. Our experience working around the world is there's some sites where that hasn't been standardized, it has not been implemented a particular feeding protocol, and those sites will really struggle reaching optimal protein and energy targets. And so I'm going to take a strong stance here and say you have to have some form of a standardized feeding protocol in your unit. I'm not saying you have to have a PEPA protocol, or I'm not specifying exactly what the feeding protocol is, but rather you need to demonstrate that you've organized your nutrition practice, you've got a protocol, and that it's standardized and understood by all the clinicians working in your ICU. The next one also might be an issue for some of you. I mean, you are attesting to the fact that you have a range of commercial products available to you that allow you to reach those protein targets, particularly the high dose group. That you have ethics approval. I should say that most of the ICUs that participate with us have a waiver of informed consent. Because this research is practice-based and minimal risk, and we have been successful at asking for and obtaining a waiver. That means you don't have to get consent from the patient or the patient's family or their next of kin. Now, these issues are regional or local. I can't tell you whether your ethics board will allow this. All I can say is we've prepared documentation. It's all on our website to support that ask. But then, some of our sites, the ethics boards take a different view and they say, no, you must obtain informed consent. And the significance of that is, well, it just takes another chunk of time from you to be involved in this trial, because you'll have to not only qualify your patient, but go off and find that family member and obtain consent. So in places where they are able to do that with a waiver, it's just a lot easier. And then the last criteria is that, we'd like you to join the effort trial if you really like to make a contribution. Adding 1 or 2 patients or 3 or 4 or 5 patients to the trial is not that helpful to us, because your practice settings are very variable. And the way we neutralize that variability is if, let's say, you have 30 patients randomized, well, 15 of them are in the high dose group, 15 are in the usual care dose group. That kind of neutralizes that variability. And so we'd really stress that you make a commitment and join for the next 2 years and try and get at least 30 eligible patients, and then that would work for us. So those are the criteria we require for sites to participate. And I'm sorry if you don't fit those criteria. Perhaps there's some other opportunity for us to collaborate, but this is what we're asking of for the effort trial. So if you are interested, again, this is our website. You can see the icon there for the symbol for the effort trial. If you click on that, you'll go, whoops, I didn't mean to click on that. Now I just left the presentation. Okay, so let me figure this out. I'm gonna just stop sharing. Well, anyway, I'm on the website now. So you'll see here, there's a little bit of there's a video down here that shows you walks you through the effort website so you can learn how to navigate it. If you push this button, getting started, then you'll see all the information you need to get started, registered, prepare and promote to begin, and then recruit patients, collect data, and then the reports. And so it's all here. If you click on these crosses, it expands the sections, and so you get more information as you click on the header. Okay, so all the documentation, all the questions that you have can all be answered and obtained here. And then eventually you're going to register by going to the system where you ask about, these are the questions that we are asking you to qualify you, and it's all online. Okay, let me just break out of that and go back to my presentation. Try that again. I don't want to keep doing that. Sorry, just bear with me. There we go. Sorry about that. Here we go. So I hope you can see my screen. I want to make reference to the technology we use to enable sort of web-based data collection, REDCap. It's an online system where once you qualify, we'll give you a username and a password, and then you just go on the web and enter in here. And within this system, you'll be able to randomize patients and also collect all your data. So it's important that you have access to the internet in your work environment to be able to randomize patients and then enroll them. So one of the biggest questions we get and one of the biggest issues we face is people are randomized, put on study, and then they don't get the amount of protein or energy that they were prescribed. And So we get a question, well, should I drop this patient out of the trial because, you know, they were randomized to get 2.2 grams per kilogram, but patient's NPO and going for surgery. And so, you know, I'm not going to be able to get that amount in. And the answer to that question is no. Once the patient is randomized, they need to stay in the trial. It's an intention to treat analysis. And so we will have all randomized patients reported on their outcomes. We recognize that some times and in some patients or on some days, you won't be successful because of those clinical characteristics. All we can say is do your best. And, you know, we live with what we get. We do have in REDCap a tool that enables you to monitor daily the amount of nutrition they get in, and it reports back to you the percent of energy and protein that they're receiving. So we strongly encourage you to daily monitor for success. And if you just define that they're not meeting their goals, that you're acting, that you're intervening. And again, this should be part of your usual practice anyway. I alluded to this earlier in the presentation, is that after you've enrolled a minimum of 4 patients, we will have a phone call with you to review your screening success, the challenges that you face enrolling, and then looking at that separation in protein intake between the 2 groups to be sure that you're, you know, contributing meaningful patients that are that have a good separation between the high and the low dose. And if not, we will give some suggestions. We'll give you another chance. And if you're willing, we can try again, and we may have a second touch base call. We will do periodic source verification as well, where we're asking you to submit your actual hospital records that we then compare to your REDCap data that you've submitted as a way of validating the data that's in our database. And then ultimately, we'll give you back a benchmark report where, as I explained at the start of the trial, all the data you've given us, we can compare the nutrition performance in your ICU to other ICUs. And again, many ICUs value that feedback. It identifies their strengths and their weaknesses and gives them something to work on. One of our biggest questions is workload. And one of my colleague, Jen Coral, she's on the line. You can perhaps see her smiley face sitting from her home in Kingston, Ontario, Canada. She's the project leader for this trial. If you have questions about start activities, she can help. The other main piece of work is around screening and enrollment. And we know that this involves some work. And so we'd encourage you to sort of pace yourself and don't come in on Monday. On Monday you come into work, you've got an eligible patient, you randomize them, you put them on trial, that's great. And then you come to work on Tuesday and you've got another 2 patients eligible, and let's grab those and put those on the trial. And by Wednesday, you got another 2 eligible. And so imagine, by Thursday, you've got 5 patients on the trial and you're not able to keep up with your usual workload, and you're not able to monitor daily the success of those effort trial patients. So slow down, take a breath, just put 1 patient on the trial at a time. Maybe eventually when you are used to the trial, mid to late through your involvement, you can have more than 1 patient on a trial. But it's okay for us if you don't enroll consecutive eligible patients. Just, screen. When you find somebody, put them on the trial, stop screening until you're comfortable that you have the capacity to put another patient on that trial. So it's more of an intermittent screening approach than a consecutive daily approach. We do stress that you need to take the time to monitor daily intake and be sure that your patients are getting at least 80%. So you have to factor that into your workload. And yes, there is some time involved in data collection. Fortunately, most of it, with the exception of the questionnaires that you must ask the family at the point that you're interacting with them early in the stay of that critically ill patient, and I've identified those questionnaires. With the exception of those questionnaires, everything else can be collected retrospectively, or said differently, when you're, got some dull time, a few hours at the end of a day, you can sit down with the chart and collect that data and enter it into REDCap. You may have questions about which data points, how. There are manuals online that explain exactly all of this. And again, if you have questions, you can reach out to Jennifer. So I'm just going to close here and say, we've learned a lot from working with other teams around the world, and having a good collaboration with the clinical teams is super important. We've demonstrated the ability to do this research nested in actual clinical practice, where we obtain a waiver of consent, and in your usual workflow, you're screening, you're assessing. Oh, you find someone eligible for effort, you take 5 minutes to log into the web, push a button, and then you're prescribing them either 2.2 or 1.2, and then the rest of your workflow continues. And so that's been very helpful to demonstrate the reality and feasibility of this trial. I've stressed this point already, but I'll stress it again, that daily monitoring of the success and whether they're getting what they've been prescribed is super important. I've stressed this point already, that you have to have equipoise and uncertainty to enable you to have success with this trial. We haven't talked a lot about this. I will refer you to the strategies to increase nutritional adequacy YouTube video I referenced to get more information on the safety and efficacy of parenteral approaches for your ICU. Please, better to reach out and ask a question than to make a mistake. That's the other lesson we've learned so far. So what I would like to close with is an open invitation for those of you who are able and interested and feel like you fit the criteria to jump on board, start with reviewing the website and getting an understanding of what's required, get ethics approval from your local site, register online, begin enrolling patients. And then, like I say, we'll have another touch base call with you individually to review your performance. And you can expect that subsequent to that, we will ask to do remote source verification on a couple of your enrolled patients. So I'll close by thanking you again for your interest and attention, and be happy to answer any questions now as I take you off mute. I can also respond to the chat button if you don't have a microphone, and I've left Critical Care Nutrition, Jennifer's email address there for any operational questions that you might have. So let me just take you on. So you're all unmuted, so just be conscious that there's 37 people online. Let me know if you have a question.
For the class, sir.
There is a question, someone who says, what happens if the RD is really interested in participating in the trial but doesn't work in an ICU? How do I obtain my waiver? It is an ICU-based trial. Fortunately, you need to collaborate with clinicians working in the ICU to make this happen.
Thank you.
What other questions do you have, please?
Thank you.
Are there any questions? I have another question. I have the same question. What if I don't work in ICU, but I have good command and anxiety? Well, again, sometimes the people who sign up with us are not the ICU clinicians, but we must have a collaboration with the ICU clinicians, ICU doctors. We require that a dietitian and a physician from your hospital to be involved in this trial. So it doesn't prevent you from getting involved. It just means you've got to build those bridges, build those relationships, and have at least one representative from the ICU on the study. Other questions? How many ICU days the patient needs to be enrolled in the study? Enrolled for the whole duration of stay. So whilst they're in the ICU, you're going to try and keep them in the protein dose that they're randomized. Remember, I said that people who come in and leave early and die quickly, those aren't helpful. The patient who stays on average 7 to 10 days helpful patient. I'd love to answer more questions. If you're not going to ask, mute your microphone, just because there is some background noise. So I'd ask you to mute the microphone if you're not going to ask questions. We have another question on COVID-19 patients. Specific entry criteria for them to have COVID-19, but they're eligible if they meet other. Cancer patients, again, I'm just going to mute you for a second. Okay, you should be able to unmute yourself if you have a question, but I have muted you again because most of the questions are coming from the chat line. And there's another question from Dr. Atta about cancer patients. The outcome here is 60-day mortality. I already said that if somebody's going to come in and die or have life support treatments withdrawn within 7 days, then they're not a good patient. And some of those patients might be older patients with cancer where they now have aspiration pneumonia, they got lung injury, and they're in your ICU, but you know because of their poor prognosis, you're going to withdraw treatments from them. So don't put those people in the trial. But cancer per se is not an exclusion criteria. In fact, it may be the comorbidity that is driving their severe or moderate to severe malnutrition. And so we don't include them specifically, we don't exclude them specifically. Remember, our inclusion are, you could be septic, you could be a trauma patient, you could be a cancer patient, but you have to have nutrition risk and you have to have an expected duration of stay on the ventilator for more than 48 hours.
Dr. Heyland, I unfortunately lost the contact. Can you hear me?
Yeah.
Because the COVID, I had this particular question. The COVID population might not affect the mortality rate, don't you think? If there are too many patients, sometimes there's a crowd of patients coming to ICUs. So what's your take? I mean, particularly in this situation.
We can allow for severely ill COVID patients to be enrolled. Remember, they'll be hopefully equally distributed between the two groups. And I'm not sure, is a severe COVID patient any different than a severe septic shock in terms of their mortality?
Yeah.
So they both kind of have a poor outcome, but as long as they feel like this patient's going to recover, because remember, one of the exclusion criteria is if you expect them to come in and die within 7 days, don't enroll them. So hopefully it'll be a younger patient where they don't have comorbidities, where you're expecting a good outcome and you're going to struggle with them, the next 2 or 3 weeks in your ICU. Therefore, that's a great patient to put in the trial to test whether, protein really matters or not.
So there is no need to review the exclusion or inclusion criteria. This is what you are saying.
Yeah. The philosophy with this trial is it's very pragmatic. So we're trying to limit the number of exclusion criteria. There's only 5. And the philosophy with the inclusion criteria is we want nutritionally high-risk patients who are going to be in your ICU from whatever source of, led them to come into your ICU, whether they're because they have COVID, because they got hit by a car, because they have sepsis. None of that is a qualifier as to whether they come in or not. It's really, are you nutritionally high risk? So the COVID patients still need to be nutritionally high risk and need to be expected to be on a ventilator for more than 48 hours or more.
Thank you. Any other questions, please?
There are a few questions on the chat line, if I may. Does the effort trial require any specific requirements of the ICU to enroll? So I had that one slide that was the setting where I'm defining things like you need to have knowledgeable ICU practitioners who are knowledgeable of critical care nutrition. You need to have a feeding protocol. So I'll refer you to that settings slide. Again, we'll make this presentation available to Dr. Atta, who can distribute it through the network for those of you who want to review it again. And I again refer you to the website where all this information is as well. I have a question. When we have to register, is there any deadline? We're halfway through the trial. We started in 2018. We hope to finish by the end of 2021. So from this point forward, you have just under 2 years. That may seem like a long time, but if you're only enrolling 1 to 2 patients a month and you need to get 30 patients, you need to get going. Yeah, I would say if we, we'll probably close enrollment at the end of 2020. So you have till the end of the year to get involved, but I would encourage you to get going as soon as possible. Oh, another really good question. Are there any markers you can use to monitor tolerance to high dose protein? Yeah, I mean, we struggle really knowing what we should be looking at to know if this patient is getting optimal amounts of protein. Perhaps from a safety point of view, urea is the only thing really we can look at, although urea goes up for other reasons. But, guidelines suggest that if somebody is on a higher protein administration and their urea is going beyond 30 milligrams per deciliter, sorry, millimoles per liter, then perhaps back off a little bit. So I give that as a general guideline, not as an absolute. Yes, we will be sharing these presentation slides when we're done. I should turn the recording off.